I would check them for a metabolic profile. So I would check their biomarkers with the usual stuff, especially the fasting insulin, which a lot of doctors don't check because the usual GP hasn't been taught about running this test called fasting insulin. So I find so much rewarding organizing this fasting insulin test, as well as the usual fasting glucose, HbA1c, cholesterol. And when I look at the cholesterol, I mainly look at the triglyceride and the HDL. I do get a lot that I don't eat sugar, but they don't understand that it's all hidden everywhere, like in the sauces and tomato sauce, barbecue sauce, even in the muesli bar or protein bar or snacks. They just don't understand it. So they don't understand that the fruit, the high sugar fruit, the banana and the grapes will push the sugar up even more.
Hello, everyone. This is Nayiri from Low Carbon Fasting. My guest today is a GP, medical doctor from Melbourne. Melbourne. She's been a general practitioner for over 20 years. She
Mm.
has qualifications in low carbohydrate nutrition. She's trained with a nutrition network and affiliated with them as well. She's also received some training or qualifications from the Australasian College of Nutrition and Environment Medicine. She runs her low carb clinic now that focuses on weight loss and the reversal of chronic diseases. Dr. Avi Charlton, welcome to Low Carbon Fasting.
Thank you. Thank you, Nari. I just looked at your website. You look pretty similar to what I do. We're all on the same page.
We are on the same page, except that I'm not a GP. So, but yeah, I'm a coach. So, thank you so much for looking at my website. Did I pronounce your name correctly, Avi?
Avi. Avi.
Avi. I'm gonna correct that. Okay.
That's all right.
Let's let's talk about your transition from
Mm.
classically trained GP to low carbohydrate nutrition, because I'm pretty sure in Australia, well,
Mm.
as in the rest of the world, you
Mm.
weren't trained in ketosis and the therapeutic effects of carbohydrate restriction. Let's talk about your transition.
Yeah. It's been an amazing journey. So what happened was maybe 7 or 8 years ago, I decided that I'm going to go to the gym and do a personal transformation journey. What happened was one day in the clinic, I was tired and I had young kids. I was just trying to juggle too many things, trying to be a GP as well as look after my children. And I was a bit chubby for a Chinese lady. One of the patients came in and just a normal consultation. She asked me, "Oh, you're pregnant. Have you got a baby expecting?" And I was so embarrassed that I wasn't. And that was my wake-up call that I have to look after myself. So I got home and looked at the local gym and booked an appointment to go and have a chat and allocated a couple of days in my week to go and start doing gym. And after about 3 months, nothing changed. I didn't lose any weight. I did work out 3 times a week, but I haven't lost any weight. So my one of the trainers suggested, oh, there's this 8-week body transformation challenge. You can join this challenge and see how you go, and it'll be good fun. So I paid a little bit of extra money and decided to just join this challenge for fun because I like to try new things. And this 8-week body transformation challenge, the personal trainer put on a spreadsheet what I had to not what I had to eat, but I had to measure my food. So I had to put so much protein, 120 gram of protein, 20 gram of carbs, and 30 gram of fat on the scale and weigh it. So I did that for 8 weeks and I won the challenge and lost 4 kilos. And I'm very small built. I'm only 5 foot tall, very small built Chinese. And so it was amazing. And I opened up my eyes to, oh, wow, what happened? This is a ketogenic diet, low carb. And I looked into the science. I did learning with low carb down under with a doctor's weekend course. And then COVID hit, and I did more courses with Nutrition Network, and I also certified myself as a metabolic health practitioner with the Society of Metabolic Health, same as yourself. So it's been an amazing journey. And so I transitioned from a normal GP who was scared of cholesterol to now totally different, prescribing therapeutic carbohydrate restrictions and spending a lot of time interpreting cholesterol results for patients who are worried. So I decided to brand my clinic 2.5 years ago as Melbourne Low Carb Clinic because I just want to reach out more and have a big sign out the door that you're here to talk about low carb. And it certainly worked, and people come from all over Melbourne and Victoria and even interstate of Australia. I did have a couple of people contacting me from overseas, but unfortunately, with medical indemnity, I can't really see them as patient. So it's been an amazing journey so far, and I'm wanting to get into speaking and spread the message on how amazing low carb is for so many conditions and taking people off medications for diabetics and people with high blood pressure. It's much more rewarding than the usual general practice. I'm still practicing usual general practice, but I do a lot of time with my low carb clinic.
I'm interested, Avi, if you were able to actually talk about low carbohydrate nutrition as a general
Yeah,
practitioner. I mean, are there any guidelines that restrict what you can advise people or no longer? Um,
no longer. No. This
mm.
has been a uh, big area of concern back way before I started. Your listeners can look up Dr. Gary Fettke.
I've interviewed him, so I'll put the link
Oh,
below.
have you? Okay, yeah, yeah. So he was openly talking about low carb, and then he was reported by the dietitians that he's an orthopedic surgeon. He's not supposed to talk about diets. But I think he went into the court, and then he got the ruling that it's fine, and he won the case. Is that how you understand it, Nayiri?
Yes, yes.
Yeah, yeah. So we are allowed to talk about low carb now.
Mm.
And there's the Australasian Metabolic Health Society, which is really trying to push forward to educate other doctors on how therapeutic carbohydrate restriction can be part of the treatment.
I think a large part of the training for general practitioners who are learning about TCR
Yes.
would be how to de-prescribe because that's not part of your classical training, right?
Yeah, that's right. Yeah. So yeah, I've been to quite a few talks and also through Nutrition Network about deprescribing, and it's so wonderful. It's so rewarding, and patients come out of the clinic off to medication already, and they're very thankful that, oh my God, I don't have to take this anymore. And sometimes they stop some of the medication for diabetes, and there's wean down the carbohydrates, and their sugars is just the same or even gradually even better. So I think that's absolutely amazing that we all should be doing this, and even the normal doctors should really learn how to de-prescribe and take people off medications.
What are some of the common medications that you find yourself deprescribing? Obviously, you mentioned diabetes. Some of diabetes medications need to be tapered
Yes.
down, eventually
Yeah.
eliminated. But what are
Yeah. 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 Most of the time it's a diabetic
Mm.
medications that when they come in and they're ready, then I would halve their insulin dose and get them to monitor their blood sugar a bit more often. And even the some of the the hypoglycemic medications like sulfonylureas can be taken off. And eventually the patient wants to take off more and more. And yeah, so the diabetic medications is the most common one. But the blood pressure tablets, the antihypertensives, can be taken off as well, especially the diuretics. And quite often, even the more common blood pressure tablets, sometimes we can halve them and get them to keep checking. If it creeps up, we can always reintroduce it. And some patients have told me that they've got off the ADHD medication
Mm.
and don't need it anymore, but not through my guidance because I'm just quite careful with the psychiatric medications. But sometimes antidepressants can be prescribed depending on how they feel. So certainly it's one of the best part of the job.
Uh, 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 how about cholesterol lowering medications?
Oh, yes, yes. So cholesterol, I leave it up to the patient. I give them the information. Quite often when they come in, they don't want to take it anyway, but quite often their usual doctors want them to be taking it. And I gather the information. Sometimes I organize a coronary artery calcium score and I put it into an equation and I tell them if your triglyceride is low and your HDL is high, we'll put it into a calculator so we can look up a calculator called the MESA cardiovascular risk calculator. And I tell them, look, if you take it, this is the risk. If you don't take it, this is the risk. Then I leave it up to the patient to decide because this is informed consent and risks against the benefits. It is up to them to make a decision.
Yeah, I find that that's the missing link in
Yes.
general medicine. We're not informed. We're told to take medication. We're not even given the information on side effects of
Yes.
medications we're put on for the rest of our lives. So
I know.
I think if more people become aware that, hey, in the long run,
Mm.
this may keep your blood sugars lower, but it's going to damage your kidneys. And I'm just giving random examples here.
Yeah.
People will
Yep.
be more cautious of, is there anything else I can do? So
Yeah.
yeah, I think that's, I have an issue with that. And GPs don't have enough time. I know here in the
Exactly.
UK it's 10
Yes.
minutes so per visit. So I don't know
Yes.
about Australia.
Yeah, we are very similar. So my usual clinic is 10 minutes,
10 minutes.
but because I've set up the Melbourne Low Carb Clinic, I've designed it to be 45 minutes or 30 minutes or 15 minutes for reviews. Even 45 minutes, I still find it's a bit of a rush and still not enough time to go through all the information I would like to go through. And I'm thinking of having an option of 60 minutes, but I'm still thinking and pondering about that at the moment.
Maybe I know you have obviously very similar, not exactly the same, but very similar form of healthcare in Australia as we have here in the UK. So
Yeah.
is your low carb clinic, which is separate from your GP practice, but is that covered by the healthcare system or do patients pay?
Yeah, it
Um,
is part of my GP clinic. We
ah,
call it GP with special interest.
oh, okay.
So it is a GP clinic and the patients just get paid. So they pay a little bit higher rate, but they get, we call a Medicare rebate.
Mm,
It's just the GP rates that I give them. So let's say if they're booking for a 45-minute consultation, then they pay 330 and they get back $120 from we call it Medicare rebate.
mhm,
Then we've got a bulk billing system, which some GPs decide to bulk bill, means that the patients don't have anything out of pocket. So for that 45 minutes, the patients don't have anything out of pocket, and the doctor will get $120 from Medicare for the 45-minute, which actually the doctor makes a loss because if we see four people 10 minutes each, we actually end up making much more money than if we see a person 45 minutes. So the GPs don't get rewarded for longer consultations unless we decide to not uh, go through, we call it bulk billing. So, and I actually find that if the patient pays the money, they actually have much more incentive to have a lifestyle change because they've invested and paid the $300 to spend the 45 minutes with me, and they want to succeed and they don't want to waste the money that they've paid. So I think that is a much better healthcare system for patients to pay some and not just rely on the government. I'm not exactly sure how it works in the UK.
We don't pay at all here, but
Yes.
yeah, we don't pay at all. But then again, most of these low carb clinics are run either by voluntary coaches.
Okay.
Um, but I know Dr. Unwin does it, but he doesn't get extra pay for this additional clinic.
All right.
It's a
Yep, yep.
completely different system. However, are there any other GPs who are with you in the low carb clinic as well? Do you have any help?
No.
You're the only one.
No, I'm the only one. I do work in a group practice, but that's with the usual GP clinic that I've been with for 20 years. So I'm still in the same location, but I've put my brand out as Melbourne Low Carb Clinic in the same location. So it's a different business in the same GP practice. There's about 10, 15 GPs there, and none of them practice low carb.
Avi, I heard recently you're collaborating with, or you're working on a project with Carla Beat Carter. So I've interviewed her as well. So I'll put her link below. So she's a qualified
Yeah.
nutritionist and low carb, specialized in low carb nutrition. So what's that project about? I'm excited about that because I have
Yeah.
great respect for both of you. So I think
Oh,
together you
thank
will
you.
come up with
Thank you.
something wonderful.
Yeah, so Carla's got a nutrition background. Sorry, she's a nutritionist and she's got a psychology background. So she's done some psychology training. So she's all into talking to people, patients about mindset and meditation, mindfulness, mindful eating, and how to be consistent, accountability, all those things. So we've known each other for a couple of years and we've become friends and catch up in our own times, and we've both got teenage boys. So we were relating to each other and became close as a friendship. But we thought working together as a team will help with our patients and it'll help both of us as well. So it's actually, I've just put in the social media just today that we're launching this program together, and I've got a podcast episode that's released today. My podcast is called Prescribing Lifestyle. I must invite you to come to my podcast as well.
Thank you.
So, Carla and I recorded this podcast episode, and it's released today about this collaboration. We've designed this program called the Metabolic Makeover Program, which is a program which includes 2 doctor consultations and 4 health coach Carla consultations. And I'm going to throw in my book and an online course and my membership program called Low Carb Pro, which I Zoom my members every 2 weeks. So all this, and people who sign up to this package can save themselves $500. So for a normal price, a whole thing, the value of the whole package is about 1,500, and we're selling this for 999. So the patients are getting more value. We are getting a more consistent workflow, hopefully. And absolutely, this will be much more rewarding work for us. And we can talk to each other and we can get the benefits of me as a doctor organizing blood tests and getting checkups, and Carla, who knows mindset, psychology, nutrition, and people can get 50 minutes of her for 4 times in this package. So yeah, that's just announced on our social media, and we're very excited about it.
Now, I'm excited about it too. When I know Carla's patience and her approach is so calm, non-confrontational. So I occasionally see her answering on other completely different accounts, genuine
Yes.
questions that people ask about cholesterol, and Carla comes in and explains in a very calm way. And I have great respect for her. You know,
Oh,
I don't
yeah.
give that much time, but she genuinely gives it time to compose information that's relatable to the general public. So you're gonna make a good team together. I'm excited
Yeah,
for this
yeah.
project.
Thank
So
you. Yeah, I'm hoping to work as a team, and that might help both of us. Like we can collaborate with ideas, we can teach each other things that we might be missing, and it'll be a great learning journey as well.
maybe you mentioned blood tests. So
Mm.
what blood tests do you usually run on people in your low carb clinic?
Yeah,
Focus
most
on.
patients want blood tests. I would check them for a metabolic profile. So I would check their biomarkers with the usual stuff, especially the fasting insulin, which a lot of doctors don't check because the usual GP hasn't been taught about running this test called fasting insulin. So I find so much rewarding organizing this fasting insulin test, as well as the usual fasting glucose, HbA1c, cholesterol. And when I look at the cholesterol, I mainly look at the triglyceride and the HDL, as well as the the total and the LDL, but more the triglyceride and the HDL. And then the CRP is another good one that I like to put in myself, and the usual GP doesn't usually check that. Um, Vitamin D is very important. Iron studies and thyroid function is also very important. And sometimes I like to check nutrient levels like zinc and copper. Quite a lot of people are low in zinc. So supplementing with them with either oysters if they're happy to eat oysters, or some zinc supplements can be a good idea. Um, that's the
B12.
most usual things I would, yeah, B12, folate, I would organize those as well. And yeah, those are the usual blood tests that I would organize. But there's a lot of people that wants to just come in for a checkup, and carnivores want to check, make sure they're not lacking in anything.
Do you do the particle sizes? Uh,
Yes.
uh, yeah.
Yeah, only in some patients. It is a paid test, so depends if the patient wants to do the particle size. We call it LDL subfractions here. So especially those people with high cholesterol, and they're worried because maybe their usual GP are worried about their high cholesterol, high LDL. And I usually do suggest a coronary artery calcium score as well, but more depending on if they're over 40 or over 50, then the CAC score is more important. But some people just doing the particle size, the LDL sort of fraction, they can be reassured that their pattern is, we call it pattern A, just means it's one peak, whereas pattern B is more two peaks. So if they're pattern A, they're more big, fluffy type 1, type 2 LDLs. And if they're type B, they might be more small and dense, and maybe some type 5, 6, 7. So I did it for myself one time during the COVID times at 2021. And I'm very proud that my calcium score is 0. My cholesterol was about 9, so it's very scary. And I researched a lot about cholesterol back then when I was locked down. And I did a particle size on myself, and I had mostly type 1, type 2 LDLs, and a little bit of type 3 and 4, but they still classify me as pattern A. So I was deemed a good pattern in the LDL particles. So I'm pretty happy, and I must do it again one day.
I want to come back to the CRP. That's not commonly talked about or even picked
Mm,
on. I mean, even when
mm,
someone has high CRP,
mm.
I've seen it, and I'm not a
Yes,
doctor, but I've seen it. I've seen
yes,
people coming to me, and I look at the CRP number. It says high.
yeah,
The GP's not even addressed it. Maybe they don't know where to go with it, so
yeah,
they don't know
yeah,
what to do next. If it's
mm,
high, what do you do? So just
yeah,
not talk
it,
about it. So how do you address this?
yeah,
What's a normal number or normal?
yeah. It's a bit of a mystery. I talk to the patients. This is CRP. It's an inflammatory marker, and the patients will go, "What? What sort of inflammation? Where's the inflammation?" I said, "No, we don't know. It's just inflammation in the body. I can't tell you. It could be so many things." So the perfect CRP is actually less than 1. Most people have higher CRP than 1. And I see all ranges. It could be 2, it could be 3. Most of the labs in the pathology report would report less than 10 is normal. Because if you order the CRP and let's say the patient has an infection, then it'll be 100 or 200. Let's say urine infection or a pneumonia, it'll be very high CRP. And the usual doctor would track the CRP, do the blood test, and then check that infection is gone down. But this inflammation can be chronic low-grade inflammation. So I see patients that are 2 or 3 or 4, and it's low-grade, little bit of inflammation. I explain to them, usually it's to do with their modern lifestyle. And I can't tell you what it is, but it can be so many things. It can be food, sugar, processed foods, seed oil. It can be non-food. It can be stress. So they're running around like an endless chook, high cortisol all the time. Or if they are not sleeping enough, that can also cause them to be inflamed. And or if they're not getting outside enough, not enough sunlight, not enough exercise. So all those things can raise your CRP to a chronic low-grade inflammation. And sometimes newly diagnosed diabetics, they're high sugar. I see the CRP to be quite a little bit higher, to be 10 or 15. And after prescribing a low-carb lifestyle to them, 3 months later, they'll be much better. They might be 4 or 5. So much less inflammation. And we now know that this inflammation is not just benign. It increases the risk of heart attacks, and increases the risk of cancer, and most of the chronic conditions, even Alzheimer's disease gives you aches and pains, even the fibromyalgia that Carla talks about. So it's quite important to check the CRP, and there's data correlating that high CRP correlates to increased risk of heart attacks, even better than LDL.
Yeah, I'm not surprised about that. So, okay, so fasting insulin.
Yes.
Where do you want the fasting insulin number to be? Because I mean, I've some doctors go with anything under 10 is fine. Some insist on it should be under 5. What about you? How do you?
Yeah. Yeah. There was one time there was a conference and the doctors just asked, what do you aim for with your fasting insulin? Everyone had different fears. I myself is hoping to be less than 5. And if they're less than 7 or 8, then there's not too bad. But the lab reference range they put on the pathology report, I think it's 20. I think Yeah,
here
it's
as well.
crazy. Yeah. But I also you like to calculate the HOMA IR score. The HOMA IR score is a calculation using fasting glucose and fasting insulin. So I usually just get an online calculator, punch in these two numbers and work out the HOMA IR, and it's useful to track 3 months down the track what the progression of HOMA IR is. And I think if it's over 2 with the HOMA IR, you've got higher chance of insulin resistance. So that just adds to the information of the whole person rather than just one number. And again, you should look at the HbA1c, fasting insulin, fasting glucose, triglyceride, HDL, waist circumference, and if they've got other symptoms, to all incorporate it to work out how you assess this person's metabolic health rather than just one single number.
Mm-hmm. Let's talk about carbohydrate reduction or restriction. Well, reduction, I think, is probably sounds less offensive, right? Okay, so what's your recommendation? Because Dr. Westman, Dr. Eric Westman,
Yes.
always, forever, for decades, gone
Mhm.
with under 20 grams of carbs. He says, I
Yes,
want
yes,
success in everyone. If I recommend under 20 to everyone, everyone will succeed, right? Uh, so that's his approach, and it works. We know it works. However,
yeah,
I know I've interviewed so many other practitioners, and they say, well, it depends on the person, and we kind of adjust it depending on, where that person is and how sustainable it is for them, because at the end of the day, it has to be sustainable. What's your
yes,
recommendation when it comes to
absolutely.
carbohydrate limit?
It really depends.
Mm.
It really depends on the person. Um, I was just talking to a researcher on with the defeat diabetes a couple of weeks ago, and she said, you've got to remember that you and I have done this for quite a few years. There's people, there's people that have just started going from 200 gram of carbs a day to 100 gram. That's actually a really big improvement. So some reduction is much better than no reduction. And the more you reduce, the better it is. But if you reduce a bit and then gradually go on the journey and reduce a bit more, then every little bit of reduction is fantastic. Surely they might not get as much result if they don't reduce very much. So if they go from 200 to 100, they might not lose the weight or go or have the same effect as the ketosis diet, but they're still better off than they were. So I think, yeah, whatever suits the person. And they might decide to just change one meal at a time. They might decide to change the breakfast first and then keep going with the lunch and the dinner for now. And so that's a progression, improvement from what they did before. So I think that's great. And of course, I would like them to be as low as they can, to less than 20 will be great. But if they can't sustain it and they think it's too hard, then it's not going to work and they're going to think it's suffering. But I usually work with the patient and they decide what they want to do. And I offer them how you do you want to gradually reduce or do you want to go cold turkey? And they usually come up with what they want. And sometimes they do come up with quite strict cold turkey, really cut down, no more carbs at all, even go carnivore. Even then, some people still finds it hard to sustain and they relapse and then they might disappear and go away. It is a hard lifestyle. It's all part of the journey. Maybe they learn something from this part of their journey and then it might help them next time when they're ready to learn about the mindset that they need. So it all depends.
I was recently stunned by one of my clients who was on a high carb standard American diet, lots of takeaways and processed foods. He was probably eating like over 300 grams of carbohydrates per day. So he made a
Wow.
few changes. He's still eating some potatoes here and there and sweet
Okay.
potatoes and carbohydrates. So now he's cooking everything at home and he's
Okay.
eating average. So I calculated. So his average is about 120, 130 grams of carbohydrates. So he reduced
Mm.
his A1C without going to an extreme reduction to
Oh, wow.
non-diabetic range. And I was
Great.
stunned because I wasn't expecting that result. So obviously I thought that would be just the transition phase and then we'll have to
Yeah.
gradually reduce. And he's happy with where he is now. He's in non-diabetic range. I don't remember the exact number,
Great.
but I posted about that on Facebook because I thought,
Okay.
look, I mean, he he's doing well with 130
Yeah.
grams of carbohydrates. I mean, if I eat 130, my A1C would go right out. Oh, obviously, I'm type
Yeah.
1 diabetic, but I know many others who are not type 1 diabetic,
Yes.
and
Yeah.
their A1C would shoot right up.
Mm.
And yet this guy
Yes.
reversed his
Mm.
diabetes with probably halving, well, more than half, of reduction of his carbohydrates. So it's doable. Not everyone needs
Yes.
to go into a zero carb diet to
Absolutely.
achieve success. So give it a go. Give it a go. I always tell people just try it. Try it for three
Yeah.
months.
Yeah. Everybody's got their own carb tolerance.
Yes.
I was actually had an opening night last night, and Peter Bruckner was saying you've got to find your own carb tolerance. So some people, especially those who exercise more, they might be able to tolerate a little bit more carbs with if they concentrate on the whole food, potatoes, or even fruit as carbs, then they might be able to get away with it. But if you're tightly controlled type 2 diabetic and you want to lose fat, then you probably, if you go as slow as you can, then you get much better results. So everyone's got different carb tolerance, and the men do it so much better. The ladies are much harder, and I think we worry much more. We've got hormones going on up and down.
Mhm.
So it's so different. Everyone's different.
It is different. What's the sort of the more prominent gender in among your patients? Are there more females interested perhaps in weight loss because you specifically write you're specialized in weight loss as well, or is it
Yeah.
men?
I get a bit of both.
Mhm.
Maybe women a bit more because again, I'm trying to help people lose weight. But there are men who have diabetes and nobody's told them how to control them with the diet and keep getting more and more medications. And they have fantastic success, the men. And then there's other men who wants to have mental health benefits from therapeutic carbohydrate reduction. Like there's a patient who had ADHD and he did very well. And there's another man who wants to control his depression, anxiety with his diet, and then he's done fantastic, and he wants to have a phone call with me every 4 weeks just to have accountability, and then he stopped booking in these phone calls. I hope he's still on track and going okay. So it's hard to know.
Um, okay. I want to talk about general sort of population's knowledge of carbohydrates. I've been coaching for a few years now. I've
Mm,
observed that many people understand protein, right? When you say
yes,
protein, they know that's fish or meat, right? Or
yes,
legumes for some people. When you say fats, they know, oh, nuts, cashews, and whatever. They contain lots of fat, and butter is fat. But they don't have the same knowledge about carbohydrates, because when you mention carbohydrates, people go, is that like sugar? Okay, but I don't eat sugar. And then you look
yes.
at diet and there's honey there and maple syrup and
Yeah, that's
cereals.
right.
Do you
Yeah.
find that? Where does that
Yeah, I
come
do. I know it's hard. People don't understand carbohydrates.
from?
And actually, someone asked me, "What's carbs? What food is carbs?"
Yes.
It's that I have to point out that it's a bread, potato, pasta, sugar, biscuits, cakes, and then they go, "Oh, all the good stuff. I can't eat all the good stuff," and that's the usual comment. And I do get a lot that I don't eat sugar. But they don't understand that it's all hidden everywhere, like in the sauces and tomato sauce, barbecue sauce, even in the muesli bar or protein bar or snacks. They just don't understand it. And most people don't understand the fruit are all carbohydrates as well. And they think that eating heaps of fruit is wonderful. They have a banana with the smoothie and they have to have so much fruit to help with fiber and the bowels. So they don't understand that the fruit, the high sugar fruit, the banana and the grapes will push the sugar up even more. So it takes a bit of education. And I have a food list, much like most other metabolic health practitioners, to give them. And if they stick to the food list, quite often they are pretty good and they work well.
Is so how what does your food list look like? Do you have the I think Nutrition Network certainly use the orange uh,
Yes.
orange list, red and green. Do you
Yeah, I
do
actually,
something like that?
yeah, I've got a very similar food list. I use the one Peter Bruckner produced with his book, A Fat Load of Good. So it's on his website, A Fat Load of Good website. And I've asked him for permission and he said, yeah, go ahead, you can use it. So I've got it, I've got his list on my book and I give it away this list a lot. And I've had so much success because this list just fits into one page with the green list and the orange list and the red list. So green list is all the protein, meat, eggs, chicken, fish, and the above ground veggies, and even some berries and lemon and kombucha and sugar replacements like erythritol and stevia. And then the orange list got all the sweet potatoes, even corn and some like beetroot, carrot, something like that. I haven't looked at the list for a while, but I think it's just a in between. And the red list is the sugar, biscuits, cakes, bread, oats, muesli bars. So you can find this list in Peter Bruckner's website, A Fat Lot of Good.
You know, people here people talk about low carb as this fat diet, this new thing, this new trend that's gonna come and go. And you'll be surprised to hear when I was diagnosed with type 1 diabetes, I was 5 years old and it was 1978.
Yeah,
I was at the
wow.
hospital. Yeah, I was at the hospital. So that's 47 years of type 1. I always forget how many years
Yep.
because I forget my age. So, anyway, so 47 years of type 1 for me. When I was
Yeah.
diagnosed, 1978,
Okay.
at the hospital, my mother was given a piece of paper by the doctor about what sorts of foods I can and shouldn't eat.
Yeah.
We didn't have fast acting, rapid acting insulins then. So you had to
All right.
kind of watch your diet too. And it is what we now recommend as part of carbohydrate reduction.
Oh,
The
wow.
green list was all the dairy and meat and fish and lots of low carbohydrate vegetables. In the orange list was rice, bread, um, potatoes that I could have in limited portions, and it was usually a
Okay.
palm size portion. And in the red
Okay.
list was all the processed foods, biscuits, cakes, donuts,
Oh,
candy, and
wow. And did you used to carb count? Did
no,
your
no,
mom
because
learn about carb counting?
that didn't exist then. There was no carb counting.
Wow.
So I just had to eat fixed. So I took fixed doses of insulin. It was intermediate acting insulin. There was no rapid insulin. Intermediate acting insulin at certain times every single day It was
Mm.
literally, I think initially it was just one in the morning and that was it. And then there was
Oh,
another one
wow.
added later at night. And that would cover the meals as well. But the meals had to
Mm.
be eaten at specific times. I remember being in year one, like first grade, right? And my lunchbox would arrive at my desk and everyone else is busy doing their writing and copying from the board, and I'll be sitting in there eating. It was just so embarrassing for me, but I had to eat at specific times.
All right.
But it was a much better way of I didn't have hypers, I didn't have hypos. It was smooth sailing for me. But
Wow.
interesting because now people go, oh, well, this, it's not sustainable. That's how I was raised on
Yes.
a low carbohydrate diet. Now thinking
Yeah.
it's
I know maybe back then you weren't influenced by the food pyramid and the
I
dietary
know
guidelines
that
back in the
and the
1978.
food
Not
pyramid
quite.
hadn't even made it, to the masses then, and certainly we didn't have rapid acting insulin that now people
Ah,
say, oh, take your quick acting and eat your carbs because it's supposed to match your carbs anyway, which it doesn't.
no.
But the interesting thing was that my whole extended family, because I lived with my extended family, like grandparents and my mom's brother and sister were married. They were young in their 18, 19-year-olds. They were still at home at my grandparents' home. That's everyone was eating from that list that I was, everyone, my
Lovely.
family ate the same way as I did. I never felt like I was deprived or eating differently. So
Wow, that's
it,
amazing.
I think that's probably why I don't suffer now diabetes complications after 46
Mm,
years. Um,
great.
yeah, but I always remind people of that. This isn't new. This is
Yes.
not new. This isn't bad.
Yes.
This is not new. It just makes sense. And my grandfather was diabetic, not type 1,
Mm,
type 2. Of course, it did him good as well to follow the same.
yeah. Yeah. Do everybody good. Everybody can do low carb. It's just whether they're ready or not.
Yeah. And we have too much food noise now to, yeah.
Exactly.
Um, so, and talking about carbohydrates earlier on, um, again, people don't realize that bread and potatoes, for example, it doesn't take long for them to convert into glucose and raise your blood sugar. Doesn't.
Uh,
Because when I was little, and on the rare occasion I would drop low,
yeah.
I would tell my mother I'm not feeling well, I'm shaky. She'd know straight away. And guess what she would bring me? A sandwich.
Mm,
We didn't have glucose tabs. Now I walk around with my glucose tabs everywhere, but we didn't have glucose tabs or anything fancy like that. She'd bring
yeah. Yeah.
white bread sandwich.
Yeah.
Within
Ex
10 minutes, my blood sugar was back to normal. It was a
yeah.
hypo treatment. And you tell these things to people and they don't really conceptualize.
Yeah. Yeah. Such a different world.
Bread is sugar, potatoes is sugar, rice is sugar. And I think
That's
there's a
right.
social media post someone has shared in the past and I've saved it. Like bread is sugar, potatoes sugar, rice,
Yes.
oatmeal is sugar.
Yeah, everyone thinks oatmeal is so good for you, so fantastic.
Yeah.
Yeah, so much industry influence.
Yeah. So Evie, do you do have any vegetarian or kind of vegan patients?
Yeah, I
What
do.
do you do with them?
Usually not, but sometimes there's a vegetarian, and especially with Indian culture, we do have a lot of Indian in Australia, and a lot of them have never eaten meat, and they can't start eating, and they're religious, they don't eat meat. If they're vegetarian, it's much easier than a vegan. And then I usually ask them to incorporate a bit more of the dairy or yogurt, eggs, nuts and seeds, even some legumes and lentils. Uh, they're a little bit higher carb, but they're probably to increase the protein intake, they're probably okay. But it's much harder to do low carb as a vegetarian. But vegan, I do find it very difficult to advise those patients. Their diet is so limited with not even eggs or dairy. I find it really hard. And I have refused one vegan. I just can't. I don't want to look after her because I find if I don't, if she doesn't have improvement, then it's not my diet. It's her. So I refused that particular person that if when she came in to seek my medical help.
Yeah. But I have to tell people it's doable. You can do it as a vegetarian because I did it.
Mm.
I started low
Oh,
carb
really?
2015, and I was a vegetarian back then.
Okay.
2015, I
Yeah.
did it as a vegetarian. I remember the 9 egg omelets I would just devour. You have to eat a lot more eggs than you've
Yep.
ever eaten in your entire life.
Yeah.
Maybe even more dairy, but I did it for maybe three years as a
Oh,
vegetarian.
wow.
Yeah, so it's doable, but you have to eat a lot more eggs. It's not like the
Yeah.
two boiled eggs in the morning and I'm done. No, that's not going to be sufficient. So,
Yeah, that's right. We've actually got an egg shortage in Australia. We can't get
oh,
eggs. Yeah, there's a chicken with the bird flu, and they've been slaughtered. I don't know, the chickens or the eggs are not making it into the supermarket.
well, that's sad because I mean we haven't seen anything here in the UK and
Okay.
the
Yeah.
same prices are relatively low, at least compared to the US, because I was in the US last year. So it's probably 50% less here, maybe more. So we're lucky in that sense. We haven't really seen the sort of egg shortages. Coming back to your female
Mm,
patients, if they are in perimenopause, menopause sort of stage,
yeah.
do you find it that it's much tougher to address their insulin resistance because cortisol levels will be higher usually, they're not
Yeah.
sleeping well,
That's right. Yes.
and that has an effect on blood sugars the next day. So
Yeah. Absolutely.
what do you do with them?
Yeah, the perimenopausal women, their estrogen are up and down, and they've got symptoms, they've got hot flushes, mood swings, brain fog, and they're so busy running around with teenage kids like me. So I'm classic perimenopause age, but luckily I haven't got many symptoms. And they don't have time for themselves because they're looking after the kids and they're looking after their elderly parents. So uh, when their estrogen goes up and down and eventually run out, quite often the insulin resistance gets worse. And they say that I'm just eating the same food as I used to, but it doesn't work for them anymore. So if they keep eating and keep doing the same thing, and their insulin resistance just getting worse, they would continue to build belly fat more and more in the midsection. And quite often that the insulin resistance gets worse and they get more inflamed, they get even more brain fog, and then they keep putting more weight on, and it's just a vicious cycle. They get more hungry, they can't sleep, and they don't function properly. So it's quite difficult. And I've actually just had a weekend of learning about menopause in Sydney. There's a group of menopause doctors that's trying to raise awareness on prescribing hormones. And because a lot of doctors haven't been trained about menopause hormone therapy or hormone replacement therapy, there's this big gap in 20 years that we are scared because of the Women's Health Initiative, the big study that was done 20 years ago. So all these doctors are scared of prescribing hormones, and women's are still getting more and more hormonal symptoms and eat maybe more because there's more junk food, sugars, and more insulin resistance. And so I'm more and more open to prescribing hormone therapy, but I also accompany the talk about lifestyle, that they have to start looking after themselves. They've got to start looking after their nutrition, their sleep, start building strength, because otherwise their muscle and bones will go wasting, and stress management. Because so I talk about all these four things about lifestyle, as well as maybe give them a blood test to check something, maybe the hormones, maybe the things that we've talked about before. And then I really would consider hormone therapy for those women, which might help them to feel better, less brain fog, function better. Then they can start looking after themselves with eating and strength training, and start improving their lifestyle as well. So yeah, that's a very huge topic, Nayiri.
Yeah, and it's very close to my heart. I'm probably a little more advanced in my perimenopause. I haven't hit full menopause yet, but I'm
Yeah.
a little more advanced. But it was torture. The symptoms
Mm,
on online, it was on Instagram. I saw a reel one day, and a menopause doctor mentioned, like, listed about 27 common
mm,
and less common symptoms. And I
yeah.
took a screenshot of it, and I thought I'm just going to start checking the ones, like, ticking.
Mm-hmm.
I was experiencing 25 of them. So I thought, no wonder my life has changed, and I'm like
Mm.
not feeling well at all. So hormone therapy made a large difference in
Oh,
me
okay.
because now I'm able to sleep. I put
Okay,
my head down
great.
and I wake up in the morning. I wasn't able to sleep. I was getting up like 3 times at night and changing pajamas because I was covered in sweat. And so
Wow.
replacement therapy, if it didn't address anything else, and I don't think it addressed the fatigue, but it addressed at least the hot flashes. I'm
Yeah,
able
yeah.
to sleep well at night.
Okay,
But the
great.
next day, now I'm taking actually less insulin. Some more
Oh,
insulin,
good.
so it's incredible. I mean, I reduced my insulin from 24, 25, 26 units total.
Yeah.
Now I take about 17, and that's more than enough.
Okay.
And that's because of the hormone replacement therapy. So
Yeah,
I mentioned that it made a huge difference.
great. And I
Me.
found myself thinking about, because I have no symptoms of menopause, or at least I'm managing fantastic. I'm just wondering, should I still consider it, even not for the symptoms, but for all the other benefits that the hormone replacement will give you, like um, bone health, muscle health, and improved cardiovascular health, and even the skin health and collagen. So that's
And
what I've been thinking about.
brain health because
Brain health, yeah, Alzheimer's disease, yeah, prevention. So
uh-huh.
I've been thinking about that, but I haven't really come to a conclusion if whether I should take it for prevention rather than symptom relief.
I mean, if I didn't have any symptoms, I probably wouldn't even think of it.
Mm,
But even with the symptoms, initially, I didn't think it was perimenopause because I didn't know much about it. Um,
okay.
yeah, I thought, what can I change in my diet? Because my nutrition was already good. I have a good
Yeah.
lifestyle, I work out, I exercise, I'm not overweight.
Mm,
So I just couldn't understand what was happening to me. And then I thought, so this is perimenopause.
yeah, yeah. What pushed me was a patient who does low carb for a few years. She's got a perfect lifestyle. She does exercise. She doesn't think she's stressed, and she was thinking it's the hormones, and she wanted me to learn more and more, and she was pushing me to go and learn about hormones. And yeah, it's so much to learn. It's never ending story. It's been amazing.
Maybe before we wrap this up, tell me about where we stand with the whole TCR movement or therapeutic carbohydrate reduction movement in Australia, or at least your part of Australia.
I think it's getting more and more good uptake, and patients are talking about it more. Even the patients who just come into the normal GP clinic, not the low carb clinic, they are saying, "Oh, I've gone carnivore, and I feel amazing. I've lost so much weight. So just even you pull someone out of nowhere and you would get someone who has heard about it. And he said, it's all over social media. So there are people who's trying it. And as I said, Peter Bruckner's done a lot of work in talking to the GP College, the Royal Australian College of GP, and getting an education day done in Sydney. I think it's end of the month. So there's more and more education done. There's more doctors interested. And sometimes I post on social media about TCR and how doctors should all looking at. I'm getting less kickbacks because maybe a couple of years ago they all say, "Oh, it's not sustainable. The patient can't do it." Now the doctors are more open about it, and then they all say, "Oh, amazing! You're reducing so much with the HbA1c." So I think it's improving in the movement.
That's wonderful to hear. I think it's globally, it's like
Mm,
gaining traction. And
yeah.
it started off with people like you and I, maybe, it started,
Yeah.
it was a grassroots movement. We didn't wait for our government to change policies on this or that. So everyone who's kind of promoting, talking about this lifestyle is doing a good job, is helping grow
Mm.
the movement. Avi, any last minute uh, points you'd like to add before I say goodbye?
Um, no, I'm very amazed and rewarded by this movement and this whole lifestyle of mine. And I feel like people should look into it and just try it out. And I feel like I've got so much energy and I feel younger than I did before. So all the listeners should give it a go. And all practitioners should try it for themselves and give patients the option of giving them the treatment of this. And yeah, there's lots of resources on my website, and I've got a podcast. People can follow me on social media under Dr. Charlton Lifestyle GP. And my podcast is Prescribing Lifestyle, which I'll send you the link. I want to invite you, Nayiri, to come on as my guest as well.
Thank you. That'll be an honor, Avi. I'm going to let you enjoy your evening. And I'm just starting my morning now in the UK.
Lovely.
So, Avi, thank you so much. This was an honor.
Thank you, Nayiri. You have a lovely day.